come to this stage, and the life will be online for some more days. Thanks to the Medical Council, Goa Medical Council, for accrediting these CMEs so that our knowledge sharing program will not be hampered. And what I am going to tell you is just the knowledge sharing which I have learned over last few years. So though I was a pediatrician, I happens to become an allergist. When once I met Dr. Major Nagaraju, who is father of pediatric allergy in India and started an allergy fellowship for all age groups, and then enhanced my knowledge by different seminars, other sessions, and got me an opportunity to present on this subject of allergy in many places in India in last couple of years. And here, thanks to the Bangladesh IMA for giving me this opportunity to share my knowledge of this subject to you all. As everybody is eagerly waiting to know what is this allergy which everybody knows since age old days, but is taking a center stage now because a lot of things are changing. Out goes the earlier infectious disease which were flooded with our OPD and hospitals, and in comes all the new things with psychiatric problem, lifestyle diseases, and all immune related diseases. And one of these where the immunity has gone wrong is being faced these days by everyone all over the globe, and we are still finding the correct solution for this of that COVID-19. And in this COVID-19 pandemic, which we are locked down, many of us in our house, we are taking a little bit break to go back to our academics and learn other subjects also. Now let's focus on allergy for next 45 minutes, which is also an immunological conditions because which we will learn. And in next few minutes, what we are going to focus is on the magnitude of problem and all other issues like in your mind that which are the positive allergens, which causes this clinical condition which you all know from respiratory allergy to anaphylaxis, urticaria. Little bit about the pathophysiology in simple explanation, how to identify these allergens. Is it possible to pinpoint on single most allergen? And is there a solution, complete solution to this allergen to up to what extent, or can completely reverse? That is what we are going to look into. And we have a good time today, the second session from maybe from 11 o'clock onwards. We can focus on all simple issues of different clinical manifestations of allergy, from wheezing in children, allergic rhinitis, to full-fledged asthma, urticaria, and any other things like venom allergy, drug allergy, and whatever comes in your mind which you want to know today, we can discuss. I'll be assisted by Dr. Uday Kapurkar, Associate Professor of Pulmonology from TMC, Dr. Sandesh Chodankar, former Associate Professor from Goa Medical College, and Dr. Rohit Hede, from dermatologist from MAPSA, in various clinical manifestations, and we can answer most of your query. This program is although specially designed for a basic doctor. We will take all issues of the general doctors and other specialties also, and whatever queries you have, please put in the chat box, and our organizing team is looking after it, and we will take the issues in the second session. So let's focus on allergy. What is this allergy? So allergy is an adverse immune reaction to a molecule called allergen. It simply means when you don't like anyone, you tell that you are allergic to that person. So something goes wrong and it's an irritable thing. And that's what happened in your nose or in your skin, and you get scratched. So why it happened, what it happened, let's see. And this is happening all over the world. India is late in joining this process. We'll come to know why. But today's burden, because of our population, if you see the world map, then the major burden lies in India and China only. But the prevalence of incidence in percentage will be much higher in Europe, America, and Australia. And not very long time from now, we will also join them. There is no other infections are decreasing. Swachh Bharat Abhiyan is a good thing, but slowly all other infections are going, vanishing with rotavirus vaccine and other vaccines. So many infections are going up. Vaccines have done something good also, but where to take and how much to take also, there should be limitations. And then the clinical manifestation starts. So what is this allergy and how it develops? I'll just explain to you in this slide, because along with the general doctors, there are many other pathologists, physiologists, so many other people from the other specialty also have joined today's program. And even when I was in second MBBS, I never understood immunology so well. And it used to be bouncer for me. I have to read it in detail when I did my fellowship. So even this pathophysiology, I'm not going to take you for a ride, but tell you in a simple way what and how the things goes wrong. Here is an example of peanut allergy, like any other. Say for example, prawn allergy. Forget, just call it a policeman. This dendritic cell are the policemen. So they take this allergen in the police station, that is our lymph node. So what is there in the lymph node? So their foreign person has come, so it's being analyzed in the lymph node. And here in the lymph node, there are two types of cells, T cell and B cell. These are important cells from immunological point of view. So just say in police station, they are presented to police sub inspector and police inspector. And what that fellow do to this antigen? If it is any foreign antigen, like usual story, one fellow gives him one side, one slave, other side, other one. So that's finished, gone. And that's what usually happen in a normal situation. So when any other viral infection or any protein comes, that's being neutralized by these two cells, and you get immunoglobulin IgG, IgM, and IgG. So first fellow who comes is a IgM, and then next fellow who comes is a IgG, and that remains for some time. So even in next time when you come, he's going to give you a quick and put you down there only. And this, what is this serology, IgG and IgM? Nowadays, everybody understood, including our politicians, bureaucrats, and reporters, very well, because their interest has been generated in this COVID-19 pandemic. So for us, this is the IgG and IgM, and it is neutralized. But here in the allergic subject, something different happened. So that of normal person, TH cell, helper cell, T lymphocyte, telling these lymphocyte to stimulate IgG and IgM, they secrete some other interleukins and they secrete IgE because of class switching. Now, why this mechanism occurs is 100% not yet understood. But the reason why it occurred an association is all those reasons which I have told you just now in the previous slide explanation. So that some interference is occurring, and in genetically prone individual, you get IgE. So what is this IgE antibody? It's an antibody against the allergen which you have eaten, that's peanut in this, for example. And then it goes in the free circulation in the body. And this is what is IgE you test when it is in the free circulation in the body for total IgE testing. But this is a specific IgE. IgE will come in the later on slide, has been stimulated by many other things. And specific IgE, because of this particular antigen, that is peanut in this case, is very, very small quantity. But that is enough. It go and sit on the mast cell. And this mast cell are there in abundance in our respiratory lining from nose down to in lung, including conjunctiva, also in the GI tract and under the skin. So till here, patients do not get any clinical manifestations. So this is called as sensitization. But IgE antibody is sitting here on mast cell. And whenever, anytime, next time, a peanut somebody will eat, he is going to give the antigen and then antibodies welcomes it. And you know that whenever antigen combines with antibody, that give rise to antigen antibody reaction, and it breaks open the mast cell and liberates all mediators of inflammation. And most abundant mediator of inflammation, as you see here, is histamine, and there are others. That's why you give many times antihistaminics. There are other mediators of inflammation also, like leukotrienes, cytokines, prostaglandin, and everything. So leukotriene has a small, anti-leukotriene has a small role. There are a lot of roles of the cytokines that here also they again, and they are interleukins, and here also in formation because of IgE formation. And the targeted therapy in future might be because of this. And because of that, many other anti-leukotrienes will come. And now what is this anti-leukotrienes, or we all come to know, because everybody has understood there is something called cytokine storm, and IL-6 is a interleukins that is being secreted in abundance in those patients COVID-19 who becomes very bad. And everybody, including our politician, everyone knows about interleukins now. Thanks for that. So interleukins comes in practice here. And what act actually against all these mediators of inflammation very easily is steroids, corticosteroids. But corticosteroids are the mainstay of anti-inflammatory therapy in all allergic clinical manifestations. But what does corticosteroids do is they not only act here at the anti-inflammation side, but they act on many other organs and giving rise to a lot of side effects. So if you have an steroid molecule which acts locally only at that particular site, then it works very well. And that is how your inhaled steroid and intranasal corticosteroid spray works. I hope you understood the pathophysiology very easily and simply. Then you can understand the allergy, why it happens, and how and what action we can do very easily. As far as immunotherapy is concerned, you reverse this cells, that T cell, giving rise to IgE, reversing back to non-IgE status. So this explains everything about allergy in nutshell, which I told you here by giving example of peanut. Okay, and let's go on to the clinical story now. So what are the common clinical manifestations of allergy? It can be just scratch to very severe anaphylaxis. But in most patients, what you get is in between. That is somewhere in between allergic rhinitis, conjunctivitis to urticaria and asthma. And when you go to the doctor with these symptoms, they all usually tell you to avoid all these things. That is from smoke to pads and from cold air to pollens. So what is this? There are some are triggers and some are allergens. Allergens are protein molecules, and non-protein molecules are triggers. So in those allergic conditions, this non-protein molecules triggers the allergic reaction and give rise to clinical symptoms or worsens the symptoms. So that is your pollution, even stress, even cold air, smoking, all these things. And exercise also increases it. What are the basic allergens are bugs like house dust mite, some pad tender allergens, proteins from pollens, and fungus. Okay, so that's what I explained just now to you. What is allergen and what is irritants? And allergy is a clinical status. So even if you have a sensitization, many of you may not have the clinical manifestations of allergy. And atopy is just a state, means you have a tendency to produce specific IgE to common allergens. That doesn't mean you have an allergic clinical manifestations. And most common allergens are for aeroallergens, that is for the respiratory allergy, is usually the mites, pollen, insects, animal dander, and fungus, and not the food antigens, which most of us think. Another important thing to understand about allergy is once you become sensitized to one particular allergen, it's a progressive disease and more allergens come into play. So initially, you may be sensitized to one allergen, and then, for example, mites in our scenario. But then with time, you can get to pollens. And then from one pollen, you can go to two, then four, five, and becomes difficult to manage. It is easy for an allergist to manage it at the lower steps when only one sensitization has occurred. It would be best if no sensitization has occurred and we have prevented. I don't think it's going to be possible because of various reasons. And when to interfere at what stage is again $1 million question, as all the world over agencies have said to interfere early. How early is very difficult to know. We'll come to know when it is, but earliest is a better. Another important thing that we should understand is there's something called allergic march. Some of you may be knowing that once you have one type of allergy, you may get others as the age advances. So when the earliest manifestation, most cases may be some food allergy. And nowadays, for various reasons, the breastfeeding is not given as it is required and number is decreasing. You may get cow's milk protein allergy or milk protein allergy, which sometimes weans off. As you see this green line, it goes off 50% in 2 years and most after 7-8 years. But those who are having cow's allergy, which may be a very mild symptom, like just pain in abdomen, and you may not even notice. Sometimes it's very irritable and found, and other symptoms come, you diagnose it. You can get in the later half of first year atopic dermatitis or dry skin. Even this in most of the subject goes unnoticed. You only get the history of all these things when you are evaluating a case of chronic allergic rhinitis and asthma, and the history will be positive. So their root lies in very young age. Even atopic dermatitis, that is dry skin, is unnoticed in most of the patients. And they just say that asa dry skin asleली पिटे असलेले. Very few of them, when they become very severe, lands up with the dermatologist, and extremely few even land up with us for evaluation when they are very difficult to treat. But these are the patients, atopic dermatitis also pass off after some years. But then comes the wheezing, which may start in the infancy, late infancy, or at 3-4 years, and many times they come down also and get a second peak again, and it may remain. Or very few of these wheezers in childhood who starts about 5-6 years of age may remain, half of them. And you have a history of atopic dermatitis and other things, other important parameters or whatever we discuss will be there as a predisposing factor for allergy. Some of the patients and many of our adult patients, they have atopic dermatitis, past history, they have wheezed in the lower age group, and then they were quite okay. And then they come in adolescence with running nose, and slowly this becomes very difficult to treat. They are the allergic people. And here we have to intervene at the right time. They are very prone for later on to inflammation of the lower airway, as the airway is same and united from nose to lungs and down. So they can go to asthma, and as the age passes, it will be difficult to treat. So what I told you is a cow's milk allergy is the one which comes very early. And it is because of the proteins. And some of the proteins are heat stable, and heat labile. So some can tolerate cooked or boiled milk, some may not. So there are different which we need to find out, and this is possible today with allergen testing and different component testing also. Here I have written that even and human milk actually contain a cow's milk protein allergen, but it is in a negligible quantity. It's very much in higher quantity in cows, buffaloes milk. And on those cows which are not fed on natural grasses, there are more allergenic. This horse milk, donkey's milk, and camel's milk is actually less allergenic, but not easily found to replace human milk. So best is to give the human milk and prevent this allergic manifestation right in the baby when he is very tender. And although most of the allergy will go, I told you 50% by 2 years, many remains. And many times, if you remove the cow's milk and give soya milk, there is very high chances to developing allergy to soya. So this is an important issue because below 6 months, you cannot give any other milk other than the milk, and another weaning food cannot be started. So substitution will have to be by extensively hydrolyzed formulas where the proteins have been removed. And the cost of this hydrolyzed formula are something around 3,500 per teen, and baby finishes it within 1 or 2 days. And then all the other problem also comes. The simple thing is focus on breast milk. As far as the next time atopic dermatitis, we'll discuss little bit in interactive session clinical manifestation. So early detection is important and recommended by all organizations, including GINA, Global Initiative Against Asthma also, and all World Allergy Organization, and ARIA, is Allergic Rhinitis and its impact, and other organizations. So how early and what we have to do? So how to diagnose an allergy? Usually for general practitioners, when you think about allergy, you think there are eosinophils raised in CBC because CBC is done everything when the cough is not going or any other condition like wheezing or running nose or blocked nose, you do eosinophils. But eosinophils are raised in so many other conditions. Earlier days, we had given hetrazan, and what we have vanished is filariasis and Lophilus pneumonia and pulmonary eosinophilia, which is not there nowadays. And even worm infestation is less. There may be some other causes also. Malignancies also can be, and so many things are there in eosinophilia comes. But indirect evidence may be there if eosinophilia is high, but it's not a diagnostic. Then there is a fad of total IgE. I told you that IgE will be raised, and 60% of the cases, even non-allergic patient will have total IgE raised. And in allergic patient also, most or half of them, IgE, total IgE may not be raised. So diagnosis is actually based on clinical symptoms. So you have to take a history in detail and very few tests. So just a word about this total IgE and serum specific IgE, because I told you in pathophysiology that it is a serum specific IgE of particular antigen that is important and has a more predictive value in diagnosing allergy and not the total IgE. But if total IgE has got a significance in some of the conditions like bronchopulmonary aspergillosis or acute fungal rhinosinusitis, where it goes very high. But in most of the allergic conditions, it may not be relevant and you have to do specific IgE. So for that, which specific IgE, which allergen, you need little bit of clinical knowledge and some knowledge we get after doing some tests and what are the allergens of our area, and that's what I'm going to give you. So if at all you want to do, you can do a specific IgE of small few antigen. You must have seen this advertises coming up in a newspaper. Within 2,000 rupees or 2,500 rupees, you are getting 250 antigens, and then they are giving some sort of treatment, and you are telling to remove all food. These are all wrong things. they are not doing the correctly because total IG, specific IG has to be tested by immunocap method. They are being done by all the major laboratory, the standard central laboratory, which the main laboratory not existing in Goa. You know, they're existing in main metros, and it costs about 1,500 rupees per antigen. Or a group of antigen about 10, they do sometime for a lower rate, about 6,000 for 10 antigens and all. Something like that can be worked out because this is all quackery. What is going on? Hope in Goa also they tried to do it, but with our efforts, it has vanished. So that's what about a serum specific IgE. What you know is little bit knowledge about local aerobiology, which I will tell you which are our colons, and that you can do, you can test because skin prick test, which is the gold standard for diagnosing allergy, may not be in hand of each and every practicing doctors. So there are intradermal tests used to be done earlier, which you have to inject much higher amount of antigenic material in the body and was a risk for anaphylaxis, which is not there in skin prick test. Patch test, we have to do some type of contact dermatitis or contact allergens to trace. Challenge tests are done by giving the same antigen and trying to know whether the manifestation comes of that particular, after giving that particular antigen. You have to do it in such high level allergy clinics or at the research level also, but not routinely. Blood tests we are available is total IgE and serum specific IgE, which I told you. But which are the best thing that is available in our armamentarium easily is skin prick test, which is done by those who are trained. There are few people, there are few doctors in Goa who do it. And serum specific IgE, which can be done if you understand this allergy by yourself also as a basic investigation. If you don't want to send your each and every patient to allergy clinic, and which is not necessary. So skin prick testing. Now, what is skin prick testing? If I have told you that IgE is sitting on mast cell in the histopathology in the simple one. So just focus. There is one cell where the IgE is sitting just below the skin, and also in your in respiratory lining, GI tract lining. These are same cells are there in the on under the skin. So if you prick it with the antigen, you will get antigen antibody reaction. Very small, minute amount of antigen is being given, and you can actually produce the reaction in front of your eyes in 15-20 minutes. So this is the gold standard. But if you analyze the serum specific IgE is a free IgE that is available in the blood. So it has not been attached to the mast cell. So this positivity doesn't mean you are allergic to this particular substance, but you are prone to allergy. Allergy will be diagnosed clinically with skin prick test, but a lot of information can get on serum specific IgE done correctly with the correct antigen also. Yes, so skin prick test is the gold standard. All organizations has endorsed it. So how we do the skin prick test? Usually done on the front side of both hands, or it can be done on back also. And you put a small amount of antigen, which is glycerinide antigen extract done from known allergens, and you take a lancet and just give a superficial prick. Not even a blood drop comes. If the blood comes, your test is wrong. And it's a painless. Even a small child can tolerate it. They don't cry, and the report can come within 15-20 minutes. 15-20 minutes, you get a bill that is measured. If it is more than 3 millimeters, it's usually positive, or more than that of your control, you give histamine as a control, which is always positive, and saline as a negative. If it is more than histamine, then it is more significant, and the higher the reaction will be, the more significant, and you have to correlate it with clinically. Supposing if the vegetarian person is there and you put a chicken and it comes positive, it has got no correlation. You have to clinically correlate it at a type of allergen that is found, that is exposed in your body, and then only you can very well correlate. Only drawback is you have to remove the antihistaminics Otherwise, your test will be false negative. So some antihistaminics like cetirizine, levocetirizine has to be removed for 7 days, and something like fexofenadine for 4 days. Inhaled medicine is not required. So you can do it with inhaled antihistaminics in nose, and inhaled steroid also. Inhaled steroid may not be removed. So it is possible, or even oral steroid sometimes we give for a short term. With long term oral steroid, you may get a false negative. So now another question that will come in your mind is how to select from so many antigens that are available. More than 200 or 250 antigens are available, and you don't need to put each and every antigen in every patient. You need to take a very detailed clinical history, and then only select which are the antigens. Like for example, in the lower age group, he is indoor, he's not outside. So his antigens will be like dust mite, some foods that has been introduced to him, milk at the lower age, wheat, peanut, not peanut is common here, fish, if it is introduced, and indoor fungus. No pollens are required. As the age increases, you may include outdoor fungus are there, and some pollens also. And adolescents and adults, depending upon their habits, sometimes even pets, if they have, there are no pets, there's no point in testing pet antigen. Sometimes it may be necessary this, if there's a clinical correlation or clinical Q is there. Pigeon also, if you point at the pigeon next to it, pigeon allergen is quite a lot. And most of you think that the food that is causing allergic. And if you go and doing the cross-sectional study in the population, you will see that almost everyone who is having allergy and is not being evaluated in detail, they are avoiding or unnecessarily stopping food. So much so that some has developed nutritional deficiency because of it. So what is important thing is food allergies also exist, but world over, these 8 food substances are the most allergic. And among them also, nuts are not very common in Goa. Peanuts, in fact, is hardly anything in India. They are there, but very less. Soy also many times we don't consume. So what is our main allergy in food is milk at the lower age group, wheat at the every other age group, eggs also come in, and many reactions, even serious reaction I have found in shellfish, that is prawns or any other shellfish, they have got a similar antigen. Fish also, but shellfish is more. So shellfish, wheat, egg are more common. Others like sesame seeds, legumes are there, and so anything for that matter can be allergic, but that is rare, and you have to go in clinical details, and you don't have to put each and every food antigen. Many times we put food antigen just to satisfy them that it is not allergic in their body, and they can start eating substances, which food substances which they have omitted from their diet. So if food is the culprit, what is the answer? You have to avoid it. You have to avoid it, you pinpoint and avoid the food substances. Food immunotherapy is not indicated and not available at the moment in the world. Only for experimental stages, it's going on. Good news is that peanut also they are doing immunotherapy in US and all. Here in one or two centers in India, even a milk immunotherapy is being done. Most others may come in time to come, and time to come we may have more allergy also. Most of the food allergy resolved by its own, those who are started in childhood, but some persist, like shellfish, fish, which starts at a later age group and persists throughout life. Peanut also can persist for life, and tree nut. Wheat is another one which is may give rise to very serious condition. So in the childhood one can go, but adult one who start may remain. Egg and cow's milk also similarly. So what happens if somebody is known and found to be allergic to pollen? He has this frustrating life, and then he puts it every time a peel of antihistaminics and take out his frustrations by saying that something is being done by trees because we have spoiled the environment, and get frustrated, or you move around with a mask like everybody moves around like this, and even allergy along with other infectious diseases are less in during this COVID pandemic. But is it possible for you to roam around freely without anything or with this smile, even when you have an allergy? Yes. For that, you need to know what is your pollen allergy, which pollen you are sensitive to, you are allergic to. And contrary to the belief that bright, colorful flowers in your garden and next door are usually not allergic. The insect pollinated flowers are usually not allergic. They're most of them grass pollinated, and we have marked and found out that which are allergenic pollens. All over India, the allergenic pollens are found, and most of our pollens are there, about 40, 50 allergenic pollens in India. Highly allergenic are 20, about 10, 20, 20, 30 among them. And it's different in different locations. Like if you go to Srinagar, you will get a birch pollen and maple and other things like exactly like what you have in Europe. But these trees are not found in other places in India. And even in Goa, although it's green and abundant with the trees, we have only very few specific highly allergenic pollens. Our main pollen allergy is from this Parthenium hysterophorus, that is called as Congress grass or a weed, and Amaranthus spinosus, something like this, and a grass pollen. The grass most important is Cynodon dactylin. Cynodon dactylin is a grass which we call as Haryari or Durva, which is offered for Ganpati. And their flowers, pollen are highly allergenic. Also other pollens like Poa and Cyprus rotundus, which are found abundantly in Goa. There is no pollen calendar has been prepared of Goa, and even good clinical study about the pollen diversity. I am working with some of the botany department of Goa University, and hopefully we may conduct a study and give exact scientific data. So now what I have done is my study of last 250, 300 in-break test that I have done with allergenic pollens of India, I have come to this two grass, 2, 3 grass, and 2 weeds are most common. Some trees like Cajulena, Equestifolia, Suruchizada, which are there in the Miramar and other beach side, also can be allergic. Magniferous indica mango, I found in few 1 or 2 patients, but not very common. Then, although coconut and papaya are been listed as allergenic, not very highly allergenic, I don't find even a single patient who is highly allergenic. This like Acacia arabica, which is very highly allergenic, very, very rarely some plants are there in Goa. Prosopis julifera is not seen in Goa, which is very highly allergenic of in India. And some plants like Halopteria are not there in Goa. So we are lucky that we are not having many allergenic pollens, and there are very few, but in time to come, new sensitization may occur as more and more people are getting allergic and more pollen sensitization occurs. Pollen calendar has been developed in many places in the world, but we have to develop in Goa. India we have, and that's how we come to know this seasonal exacerbation of asthma or allergy is there. It could be pollen. So if the pollen allergen is there, somebody like SPT we can get like this. Somebody is having a grass pollen of induration is quite high, clinically relevant, and at the lower age group and uncontrolled asthma occurring, we can do immunotherapy. So there are some 1 or 2 slides which you can take a screenshot. What one person can do if the pollen allergy. A lot of things you have to do. You have to bath, shampoo daily, limit the outdoor activity between early morning 5 to 10 because that time number is very high. Look at the pollen exposure or pollen limit on that particular day, which is not available as of now in Goa and other cities. It is easily available. In gardening, it's a problem. All these issues are there, and even when traveling, you have to see the pollen data of that particular place. In Goa, also, hopefully, we'll start giving in time to come. What about if you have an allergy to cat dander? It is a saliva actually from the cat which leaks is more allergen exponent. But what do? You squeeze the neck of the cat and close your nose. Oh my God, that's not an answer because you love them. You like them, they are there in your kitchen, they sit with them, they sleep also on your bedroom, and there is no truly hypoallergenic cat or dog is available. So you'll have to sit like this and wash, give him a good wash every week, change the clothes, do give HEPA filter, and all the other things that you have to do, because cat allergy also can persist for 12 to 16 weeks after removal also, if you can remove it, but mostly you don't like to remove it. So what you can do, if possible, you can do immunotherapy. That's possible, or you have to live with all these things. And other than cat and dog, other warm-blooded animal also, that and that can be allergic. So here is a nice room, a beautiful room, carpeted one with sofas, cushions, and in bed. And who is living there is always blocked, having a nose problem. So what is there is who lives underneath them is house dust mite, and this is a house dust mite, which is the single most important allergen in humid coastal environment like that of Goa. This is the eight-leg from the bug family, not the bed bug, who doesn't have an eyes and thriving on human skin scales which were thrown out, and lives in the fabrics. So, always like cloth material which cannot be washed and dried. So it is there in the mattresses, it is there in the pillows, it's there in the teddy bear, it's there in the curtain, carpet, everywhere. And mind you, this is the one allergen which is responsible for almost 80% of our allergy, respiratory allergy is due to house dust mite. Very difficult to control environment, do environmental control. I will tell you what you can do. And but good news is that if it is only house dust mite, then you can give a very effective immunotherapy. Can be you can build a tolerance with even sublingual immunotherapy. So if somebody is having a uncontrolled asthma, or allergic rhinitis, and or even a conjunctivitis for that matter, uh, and the reaction is showing very high, you can very well do immunotherapy. The other two slides, you can do a screenshot if you want, and I can share these slides later on also, because this program will be recorded, will be shown to you, will be given to you. So this is what all the things you have to do in environmental control of house dust mite. Some which I have told you, that washing and drying. Keep your mattress out. So mattress cannot be washed. Pillow, you can put pillow in pillowcase, some towels, and use that type of pillow and wash it again and again. Same thing, remove the carpets, use vinyl covering for your sofas, change soft toys for children to plastic toys or other toys, other material, slowly, because immediately if you remove, there can be psychological problem. Yeah, there are other things also available. You use a HEPA filter, that is a high affectionate particulate matter filter, which can be used for your AC and even for your vacuum cleaner. Humidifier, yes, certainly it might be helping to certain extent, because if you put humidity below 50%, mites doesn't survive. And there are mattress protective dust mite covers are also available, but the ideal one are very difficult to get. Some company which was there, Merck, Ergo Pharma, which are not there now, they used to get in India also, but you will have to get it from the abroad. The one which is available on online shopping, which cost hardly 2,000 rupees, may not be good mites cover. But best will be to do immunotherapy if you cannot do environment control and your symptoms are not controlled. Molds are the other one, your fungus, which grows anywhere where there is a moisture. And where is the molds can go, and which are the most aspergillus, alternaria, these are the commonest one which can give rise to your symptoms in nose and in lungs. And where are these fungus grown? Anywhere there is a moisture. The most important place, bathroom. Bathroom, whatever black thing you can see is fungus. Sometimes the leakage below your kitchen thing, which is going unnoticed, or even in your fruits which are stored outside for the time. So earlier days when there used to be open bathroom, this fungus was not there because there was no moisture accumulating in your bathroom. And nowadays also hardly any bathroom has an exhaust fan, and you are not keeping the bathroom open after the bath. So that gives rise to fungus allergy. Similar thing is the mites. Mites were not there earlier days when everybody used to sleep in earlier generation on cow dung floor and on mat. But now we are sleeping with uh, with mites. So these are the things which you can do for environmental control of your house. Remove the dampness and moisture to be avoided, and other things which you can take. Or I will share the slide. And there are fungus outside also. Whichever this dry leaves and all are fallen outside your house, they remain there for some time, and the moisture get collected, and you get a fungus on that. Earlier days, in the olden days, we used to collect those leaves and have put a fire outside and boil water that is to be used for bathing. So now they just remain like that, or even a small drain, and you can get a fungus allergy, a fungus allergy, mold allergy can develop. A word about the drug allergy. Yeah, this is iatrogenic many times, or unfortunately so. As far as which are the drug which causes the allergy, the most important thing which causes sensitive reaction are NSAIDs, and diclofenac is the most important culprit. Other ibugesic also can occur, and among the second group is antibiotics. So unnecessary use of antibiotics can give rise to very severe reaction. Penicillin groups, and nowadays most of them cephalosporin drugs. Even I encountered in my practice penicillin allergy because of protein penicillin. Because long back, about 20 years, one of my intern gave it without test dose. Luckily, the patient survived because we had adrenaline. And I know that one of the patients, even in when I was working in Asilo Hospital, developed hypersensitivity, anaphylactic reaction after Penidura, regular Penidura. So in so you have to have an adrenaline, and when in hospital, when you are starting any antibiotic or any medication, even IV drip and all, see that when the medication start or antibiotics are given, it's given very slowly. If it's not given without a test dose, and doctor is available, because any severe reaction can occur when you are giving the first dose. Desensitization protocols are available for some like aspirin, where it has to be given in some cardiac condition, but even now they are being replaced by newer other medications. Latex allergy is very common in our profession, medical profession. I had at least one doctor who had anaphylaxis, and one nurse, one or two nurses from the private hospital here in the North Goa who had reaction due to latex. And we found out after history and investigation that was a latex is a problem, and we changed, and non-latex gloves are available. The vinyl non-latex glove, nitrile vinyl gloves are easily available, which may prevent you from latex allergy. And latex also reacts with some fruits like banana. Those who have a latex allergy can have a oral allergy syndrome. Seem like some pollens are also having a cross reactivity with food, and you will get a burning sensation in the food. So wheat is another one food allergy, which is a can give rise to very serious form of anaphylaxis, up to anaphylaxis also. Wheat can and gluten inside is the most dangerous. There is one entity called food-dependent exercise-induced anaphylaxis, where you are allergic to particular food like wheat and gluten, and then if you do an exercise after consuming it within 2 hours, you can collapse and get anaphylactic reaction also. There are casualties have occurred like this, and there are patients who are saved, and on investigation has found out that this is the reason, and then we gave them advice of not to do exercise immediately after consuming this particular food. There can be barley also, which is there in the beer, can also stimulate a similar thing, or even do exercise within 2 hours. Don't take this particular food. That's the treatment. I do came across 1, 2, 3 patients like this. So this patients who has anaphylaxis has to keep emergency adrenaline with them. Unfortunately, EPIPEN, that is pre-filled series adrenaline, which most of the people, highly allergic patient or experience anaphylaxis in Western world are keeping with them, is not available here in open market in India. It costs about 5,000 rupees and has 1.5 years shelf life. Is available to not in open market in India, but not easily available. No Indian company has started it. We allergies have informed, and some companies are in the process. Hopefully they do it. Till then, what I advise or what other thing is possible is 4 months definitely EpiPen, that you can load adrenaline in an insulin syringe and keep in your specs case, because it is photosensitive. It should not be exposed to light, and write an expiry date, which usually we have 2-3 months expiry date, and change it. So this can be possible, or else you have to take a ampule and a syringe and you have to break it, which becomes very difficult on many a time when such problem occurs. So for all the others, respiratory allergy, most of the time solution could be in allergen immunotherapy. So what is this allergen immunotherapy? If you give it very early when too many sensitization has not occurred, it works fantastically. So in allergen immunotherapy, you give a same allergen. For example, in dust mite, you give dust mite only to the patient, either orally or by subcutaneous, in minute quantities, about lack of time dilutions to start with, and then gradually increase. We give it twice a week. Suppose you drop, then you give 1 drop, 2 drops, 3 drops, 4 drops, and gradually increase. And then once the one bottle is over, then you give the second bottle by increasing the concentration again. And it takes about 6 months for a upper threshold to reach. And only after about 6 months to 1 year, you may be off symptoms totally, or you may be significantly control of reducing your all the inhalers and other medication that you are taking based on your own threshold level on when we have started it. So earliest is a better to make completely non-allergic person, and it is being currently used for the treatment of allergic rhinitis, rhinoconjunctivitis, allergic asthma, and venom hypersensitivity. Very few people and very few set up experimental stage in some food immunotherapy also, like milk. It is being offered for 5 years onward for any age, but older age becomes a problem. Younger is better. It's absolutely contraindicated below 2 years, and 2 to 5 is relative contraindication. And if there is no clinical improvement after 1 year of therapy, there is no point in continuing it. And if there is a clinical improvement up by 1 year, 6 months to 1 year, it has to be continued for 3 to 5 years to get a good threshold and long-term life without immunotherapy. So that's all sublingual immunotherapy and subcutaneous immunotherapy we have. Sublingual, not even a single case of anaphylaxis has occurred. Even during skin prick test, not even a single case of anaphylaxis has been reported anywhere in the world. But for subcutaneous, yes, there are many cases in the past. So that's the reason many times patients are not coming forward for subcutaneous immunotherapy, and they have to come to the doctor's place. For sublingual immunotherapy, only the first dose at doctor's clinic and rest can be taken at their home, and only follow-up can be done. Oral tablets like this are available in US market or in Europe, not yet available in India, and not yet available freely in doctor's hand, in general doctor's hand. So at the moment, it is the immunotherapy or sublingual and subcutaneous is being done by trained allergists, and quite a few of them are available in Goa. So level of confidence is very high with dust mite, pollens, and venom immunotherapy, or even insects like cockroach. That's another one causing respiratory allergy, and molds also can be given. And so that's the final word on allergen specific immunotherapy. It's the only therapy which has a capacity to alter the natural course of disease, or else allergic conditions you have to manage sometimes lifelong with other clinical thermometrum that we have, like inhaler therapy in asthma and intranasal spray. As far as the probiotics, which is thrown in the market nowadays, no definite answer has come to that, but this is a pharma made awareness that it can, but nothing. If you just give probiotic, I don't think, and nobody has proved that your allergy will vanish. There are some studies on bifidobacter and lactobacillus GG in prevention of future allergy if they are having atopic dermatitis of primary stage and all, but nothing has been conclusive. Among the other alternative therapies and all, nothing has been proved anything. But nowadays, even in COVID era, where everybody is doing inhalation and then NATI or saline nasal wash, yes, it is useful, saline nasal wash, because it flushes your allergen. And if you do kapalbhati and nasal breathing, and then do saline nasal wash by using neti pots, which are easily available for 100 200 rupee on online platforms, and every day if you start doing it, your nasal cavity might remain free of allergen, or it can be enhanced if you have a severe allergic rhinitis. Yes, the biologicals are coming in big way, and omanizumab is already flooded in the market. It's there for many of the allergic conditions like chronic urticaria, not controlled on antihistaminics at certain level. Only by expert can use it. And even for uncontrolled asthma, there is a specific indications with related to IgE level and other conditions also. But the cost is around more than 10,000 per injections, and you have to give one injection every monthly forever. So it's not like 1 or 2 months and all, but to certain extent. And there are other pull-ups also are coming up, and now it's in news because everybody knows about tocilizumab is of the same family. In fact, the first family from the tocilizumab group, and there are many other umabs, depilumab and epilumab are coming up in time to come. They are in thousands, and some goes in lakhs, and they interact with all the interleukins at every stage, which pathophysiology have shown. And hopefully in time to come, their rate, which is approaching even a lakh, 80, 90,000, and nothing below 10,000 can go below 1,000 in time to come, and maybe in the hands of every one of us. Hopefully they may be there, and hopefully other immunotherapy also get. So what's the future of allergy management? Yes, those biologicals may be at the center stage, and rates may come down, mostly once the Indian companies start doing it. Indian companies now had come quickly for the call of developing vaccines for COVID-19. Hope they do it for this also. Oral pills as immunotherapy, and in your hands, everybody's hand, may be possible in future. There may be newer forms of immunotherapy, more standardized, more purified products, and maybe epicutaneous patch or intralymphatic 1 or 2 or 3 4 injections only, and your turn. It's possible you give injections in the lymph, the ultrasound guided. This is also been going on. Early intervention of weaning food in those with strong family, like in US and all, where peanut is creating a lot of problems. They are now introducing peanut in before 6 months, at 4 months gradually in those who are likely to get peanut allergy in future. Components of allergen for precise diagnosis. Yes, what I told is IgE, but they're antigens. And final molecule from IgE is also will be available in India shortly, and we can diagnose it very precisely. So take home messages from me is allergic disease are exponentially increasing. House dust mite. House dust mite is the single most allergen responsible for most of our respiratory allergy. And good news is that it's most sensitive to immunotherapy. Our pollen allergy in our locality is mainly due to grass and weeds like Parthenium and Amaranthus. Most of the food allergy in children will outgrow with time, but not all. But all weasels will not outgrow. They might come back again with allergic rhinitis and the second peak of asthma, which might be very bad in adults. Allergic mark is a significant phenomena in time to come. Newer modalities of treatment gives you a better quality of life, which can be enhanced by environmental control. We'll discuss that newer modalities in our discussion. Early identification of positive allergen gives one an opportunity to completely reverse the disease process by way of allergen-specific immunotherapy.